Okay, we have Dr. Harissa Hussaini Hasbullah with us. She is consultant oncologist from University Technology Mara. Her topic is current advances in neoadjuvant treatment of breast cancer. Welcome, Dr. Harissa.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the introduction, Mr. Chairperson. Thank you to the organizing committee for inviting me to speak among the surgeons today. So I am a clinical oncologist. So for us, the neoadjuvant treatment for breast cancer, nowadays, actually, there are a lot of controversy as well as dilemma. But I'll try not to talk too much about the data, but just give an overview of what's happening with regards to neoadjuvant treatment option for breast cancer patients. So the reason why we give systemic treatment before surgery in breast cancer is essentially to reduce the tumor size so that surgery can be performed in an otherwise inoperable tumor, or the aim is to reduce the tumor size enough so that breast conserving surgery can be performed safely, or to reduce the tumor size so that we can achieve better cosmesis in a small breast. So these are the typical sort of chemotherapy regimes that's being used in neoadjuvant settings in Malaysia, especially in public hospitals. Okay. The first one, the FEC regime, I think a lot of you are familiar with this. It consists of 5-FU or fluorouracil, epirubicin, and cyclophosphamide, given every 3 weeks for a maximum of 6 cycles. What people usually tend to forget with this regime is that after the 3rd cycle of FEC chemotherapy, so when the patient comes for the 4th cycle of the chemotherapy, we have to assess the tumor size properly. If the tumor hasn't shrunk to at least half of its original size prior to starting neoadjuvant treatment, then we have to change the chemotherapy from FEC, change it completely to docetaxel every 3 weeks for 3 cycles and then followed by surgery. Which is why most of the oncologists nowadays prefer the second option, which is upfront FEC for 3 cycles, followed by docetaxel for 3 cycles, especially in node-positive disease. Then the third chemotherapy regime, the TAC regime, are chemotherapy where we give concurrent docetaxel, which is a taxane with anthracycline, as well as cyclophosphamide. So this is a very toxic regime, and prophylaxis subcut GCSF is required to reduce the risk and severity of febrile neutropenia. Now, I think all of you would agree with me that regardless of which chemotherapy regime that we use, we can see that some patients would respond amazingly with the chemotherapy regime, whereas in another patient, the tumor didn't shrunk as much, even though we used the same chemotherapy. And then in a small number of patients, we may even observe progression of the disease, even though using, again, the same chemotherapy. So actually, we can predict to a certain degree who will respond to neoadjuvant treatment and how well they will respond to the neoadjuvant treatment by looking at the biopsy sample, the ER, and the HER2 status. So this table is from the important CTNE OBC group published in Lancet in 2014. What they do is that they look at a total of about 12,000 breast cancer patients who receive neoadjuvant treatment, and then they look at those who achieve pathological complete response following this neoadjuvant treatment. So what they found here is that for example, those with a hormone receptor positive, that is the ER positive tumor, but HER2 negative and has a low-grade tumor, the rate of pathological complete response is very low. It's only 7.5%. On the other hand, those with a HER2 positive tumor, hormone, but ER negative tumor and receive trastuzumab in the neoadjuvant settings, about half of them would be able to achieve pathological complete response. Similarly, those with triple negative breast cancer also respond very well to neoadjuvant chemotherapy, with about 33.6% of them achieve pathological complete response. So what this paper also shows is that pathological complete response achieved following neoadjuvant treatment in breast cancer correlates strongly with better survival. You can see here on this graph, the red line are those who achieve pathological complete response following neoadjuvant treatment. And as you can see here with the hazard ratio of 0.36, what this means is that those who achieve pathological complete response, right, have about 60% lower risk of death from the cancer compared to those who did not achieve pathological complete response. And these benefits actually are observed throughout all subtypes of breast cancer, ER positive or HER2 positive or triple negative. But the significance of the effect are actually mostly observed, especially in the aggressive tumor, the triple negative, the HER2 positive, and those with a grade 3 disease. For example, if you look right at the bottom, those with triple negative, you see the hazard ratio is 0.24 for risk of disease recurrence. What this means is that if a patient with triple negative breast cancer, they receive neoadjuvant chemotherapy and then go in for surgery, and then the pathologist couldn't find any tumor remain in that sample. So essentially, it's a complete pathological response. So there is an 80% chance that this patient has a reduction in the risk of recurrence compared to those who didn't achieve pathological complete response. Now, okay, so based on this information that I've given you, basically to summarize, if we are going to go for neoadjuvant, if we decided that a patient needs neoadjuvant chemotherapy, we have to try as much as possible to use agent that can produce pathologic complete response or PCR, because this correlates with better survivals, right? Okay, so let's go to scenarios. I have a few scenarios prepared. I think that would be better for the audience to understand where I'm coming from. So, okay, scenario number one, we have a young 35-year-old lady with locally advanced breast cancer. It's a ER negative tumor and HER2 amplified tumor. So the case was discussed in a multidisciplinary meeting with oncologists, surgeons, radiologists, and pathologists. And it was decided that the patient wants to try for a breast conserving surgery. And if we go for surgery up front, that's not possible. So everybody agreed to go for neoadjuvant treatment for this patient. So we could subject the patient to standard chemotherapy, FEC regime or FECT regime, or even the TAC regime. But we know that in this group of patients who are HER2 type breast cancer, they will respond better if we add HER2 targeted therapy in the neoadjuvant settings. Okay, for example, a lot of data shows that if you give trastuzumab in the neoadjuvant setting, at least for 3 cycles, okay, followed concurrent with chemotherapy, of course, and then followed by surgery, followed by a total of a year of adjuvant trastuzumab, then you have a higher risk of achieving pathologic complete response and also a lower risk of disease recurring after the treatment complete. So because trastuzumab is a monoclonal antibody, it's targeted therapy, it targets specifically the HER2 receptor. So addition of trastuzumab to chemotherapy in the neoadjuvant setting does not increase the incidence of neutropenia, neutropenic fever, or even cardiac events. But one thing that we have to bear in mind, one of the side effects of trastuzumab, even though the risk is low, is with regards to its cardiotoxicity. I mean, in major clinical trial, they reported about 7% risk of trastuzumab-induced cardiotoxicity. But in a retrospective study done in Malaysia, I think the rate can be as low as 3%. But nevertheless, because of this risk, we cannot give trastuzumab concurrently with anthracycline. So let's say we decided to give this patient trastuzumab together with the FECT regime in the neoadjuvant setting. The trastuzumab only starts with the T chemotherapy, the docetaxel. So in the first 3 cycles of chemotherapy, it ought to be just the chemotherapy alone. The FEC cycle 1, FEC cycle 2, FEC cycle 3. And then at cycle 4, when we start using the docetaxel, that is when we add on the trastuzumab, okay? And also you have to monitor the ejection fraction with a serial echocardiogram. Right, okay. So our patient then, we've decided to use exactly that regime. We give a FECT chemotherapy regime concurrent with neoadjuvant trastuzumab with the docetaxel part. And then breast conserving surgery was able to be performed, and miraculously, there's no more residual invasive disease present on the specimen. So this is a complete pathological response. Now, some may tend to forget that the patient in the trial that shows the benefits of trastuzumab in neoadjuvant setting, the whole package is that the patient who actually benefits from the survival in this group are those that continue on with trastuzumab in the adjuvant setting. So even though there's no more disease, right, after the new adjuvant treatment, you have to continue with the adjuvant trastuzumab every 3 weeks in the adjuvant setting, complete a total of 18 cycles. So if you have 3 cycles in the new adjuvant settings, then that's between 14 to 15 cycles in the adjuvant settings. Now, what happened if our patient, we give the same chemotherapy regime, right? FECT concurrent with trastuzumab. The tumor did shrink significantly, and then we are able to perform breast conserving surgery, but there are still some residual disease left behind in the breast. So we could traditionally, we just continue on with a total of a year of adjuvant trastuzumab every 3 weeks in the adjuvant setting. But we have this new data. It's in the Catherine trial, published in NEJM, New England Journal of Medicine 2019, that shows that instead of continuing in the adjuvant setting with trastuzumab, if we change it to a TDM1 drugs, okay, we would actually achieve better survival for this patient. So TDM1, or also known as trastuzumab emtansine, is basically a drug, emtansine, attached to trastuzumab. So trastuzumab is a monoclonal antibody, so emtansine attached to it. And the trastuzumab kind of in this setting serve as a vehicle to bring the emtansine, the drugs, towards the HER2 cancer cells. And then once there, the emtansine then can do its work to destroy the cancer cells. And these drugs, by the way, is available in Malaysia. Right, okay. So that is if we use trastuzumab alone in the neoadjuvant settings. And then there is this trial, 2 trials, the Neosphere trial, the Trifenia trial, at least it's these 2 trials, that actually use 2 HER2 receptor, just like trastuzumab. So instead of trastuzumab alone, they add on another anti-HER2, which is pertuzumab or Perjeta. Now, even though they are both anti-HER2, they act differently at the receptor, at the HER2 receptor. So they kind of like complement each other. Okay, and by doing this, these 2 trials show that the pathological complete response can be as high as 66%, and the cardiac toxicity apparently was reported to be acceptable. So again, similarly in these 2 trials, okay, so they would give the combined, the dual blockade, both the trastuzumab and pertuzumab in the neoadjuvant setting, concurrent with chemotherapy. Now, the chemotherapy backbone used in these 2 trials slightly differ, okay, but anyway, after that neoadjuvant settings, they then proceed with surgery, and then after surgery, regardless whether or not there's residual disease or not, the patient then have to continue on trastuzumab alone for a total of a year in the adjuvant setting. But then, of course, some oncologists debate that we should extrapolate maybe from the Catherine trial, that maybe in those who didn't achieve pathological complete response with dual blockade in neoadjuvant settings, we may want to change to TDM1 in the adjuvant settings. All right, okay, so I think we are done with the HER2 breast cancer in neoadjuvant settings. So let's move on to the second scenario, all right? So a young 35-year-old lady, operable 4 cm tumor, but it's in a relatively small breast compared to the tumor. And this time, the tumor is ER negative, PR negative, and HER2 negative, or also known as triple negative breast cancer. So again, this case was discussed in a multidisciplinary meeting. Oncologists, radiologists, and surgeons, pathologists are there. And it was decided to try for neoadjuvant chemotherapy because the patient wants a breast conserving surgery rather than a mastectomy. Front. So, and we know that patient with triple negative breast cancer has quite a high PCR rate and responds quite well to neoadjuvant chemotherapy. So what are the options of treatment? So I've mentioned it that in the past, it used to be chemotherapy. And the point to note here is that taxane has to be in it, because it has been shown in trials that if you leave out taxane, then the efficacy is not the same. So if we do choose chemotherapy in triple negative breast cancer in neoadjuvant setting, then I suggest we go for either the FECT regime or TAC regime. But of course, the TAC regimes are more toxic. And then there are these debate about the role of platinum-based chemotherapy. Some trials show that you can achieve significantly higher pathological complete response if you add on platinum to the chemotherapy backbone. But because some of those trials, they omit anthracycline or they omit taxane, and some people are not comfortable with omitting either or. So it's not really a standard practice to use platinum in the neoadjuvant setting for triple negative breast cancer. Certainly, if I'm going to use chemotherapy, it would be the FECT regime. But recently, just last year, Peter Schmidt and his colleague presented this interesting paper whereby if we use immunotherapy, and in that setting, it is a pembrolizumab, you actually get a higher pathological complete response. It can be as high as 64.8%. So I think with this new data, right? So in that trial, the pembro is given concurrent with chemotherapy. So you cannot leave the chemotherapy out. And the chemotherapy given was taxane. So taxane is there, and then if I'm not mistaken, there's anthracycline also, but it's not concurrent. So it's kind of like a different sort of chemotherapy that we are familiar with. But certainly this is something, if the patient can afford, if finance is not a problem, certainly this is something that we we can consider when deciding which agent to be used in neoadjuvant setting for triple negative breast cancer. So then, so our patient, no money, can't use immunotherapy, no budget. So we decided to go for the FECT, neoadjuvant chemotherapy. Patient managed to go for a breast conserving surgery. But unfortunately, there's still some residual invasive disease following the surgery. So the current practice is that if this is the case in a triple negative breast cancer, if they didn't achieve pathological complete response following neoadjuvant treatment, then there is a benefit of adding 6 to 8 cycles of oral capecitabine that's given usually every 3 weeks in the adjuvant settings, and you can get improved overall survival with this approach. And indeed, this is a current practice at what we are doing in Malaysia as well. Okay, so I think I'm done with triple negative breast cancer. So we moved on to the last group of patients. This one is actually more complicated compared to the other two, actually. There are more controversies and dilemma. Right, so now we have an elderly lady, well, not elderly, slightly older than the last two, 60-year-old lady, but fit otherwise. So ER positive, highly positive ER, HER2 negative. The tumor is operable upfront, but need mastectomy. So patient request for breast conserving surgery. So, so we need to then decide. So it was discussed in MDT, of course. And then, usually if this case is brought up in MDT, then the reaction usually are mixed, opinion are mixed, okay? So one group of patients would say that, yeah, just try with standard chemotherapy, like FECT or FEC or even TAC regime. But then the other group are saying that, look, we know that if it is an ER positive tumor, then the likelihood that the patient is going to achieve a pathological complete response is actually very low, between 10 to 15% only. Wouldn't it then be better if we just proceed with mastectomy straight away, rather than, taking our chances with this chemotherapy, which the patient may even progress while ongoing the neoadjuvant chemotherapy? So there's no right or wrong answer there. I mean, in the West, they actually, for this group of patients, they actually use neoadjuvant endocrine therapy, but very, very cautiously, and follow the patient very, very closely. And then, if after a certain time that the patient doesn't respond very well to the endocrine therapy, then they just straight away, either swap to chemotherapy or just proceed straight away for surgery. So in real practice, what happened? Well, in real practice, we would give we will try with chemotherapy. Okay, I think that is the correct approach. We should try, even though the chances that the tumor will have a pathological complete response is lower compared to in HER2 or TNBC. But this is a PCR rate, so it's not response rate. So the tumor may respond enough to enable us to avoid mastectomy and proceed with BCS. So we will proceed with that. But maybe we should look at the grade of the tumor and also maybe the proliferative Ki-67 count on the patient, because if the grade is tend to be lower grade, like 1 or 2, or a lower proliferative index, then perhaps it is less likely that the patient will respond to neoadjuvant chemotherapy, and this group of patients perhaps best to just go ahead with a surgery upfront, compared to those who are higher grade of tumor, like grade 3 or high Ki-67, then perhaps justify that if we go ahead with a neoadjuvant chemotherapy first. So just very briefly about the role of endocrine treatment in neoadjuvant setting. Currently in Malaysia, and certainly generally worldwide, this is not a standard management in neoadjuvant setting to use an endocrine treatment like tamoxifen or aromatase inhibitor, because of the concern of the delayed time to clinical response with this treatment compared to systemic chemotherapy. And usually this approach is reserved to those who are not fit or elderly, who can't tolerate chemotherapy. Then in such setting, aromatase inhibitor is then recommended. But other than that, ER positive tumor, we ought to try, I think, we ought to try with neoadjuvant chemotherapy. All right, okay. I hope I am okay with time. So there are a lot more controversies associated in neoadjuvant approach in breast cancer. For example, those nodes that disappear, can you do SLND or you have to proceed with ALND? Can you omit ALND and give radiotherapy instead? So a lot of debate, but all these cases you need to discuss in multidisciplinary meeting to achieve a proper consensus and discussion between the team members. So that brings me nicely to my concluding slide. So my point number 1, when we decide someone to go for neoadjuvant treatment, it is imperative that the case be discussed in a multidisciplinary tumor board meeting consisting of oncologists, surgeon, radiologists, and pathologists. And then my point number 2 is that you have to be clear of why we want this patient to go for neoadjuvant treatment. And if we do decide for the patient to go for neoadjuvant treatment, we have to try whenever possible to use the most effective agents available for that particular patient and try to aim for pathological complete response as much as possible. Okay, for example, trastuzumab dual blockade in HER2 breast cancer. And then my second point is that it is important, once the neoadjuvant treatment complete, surgery is done, it is important to then discuss with the oncologist as to what to do with the adjuvant setting. So sometimes the oncologist cannot give the adjuvant plan, when you first referred for the neoadjuvant treatment. It depends on what is the outcome of the surgery, whether or not there's pathologic complete response or not, for example. Okay, so it is important after neoadjuvant treatment, after the surgery, that discuss the case again with an oncologist about adjuvant. For example, adjuvant trastuzumab in HER2 amplified tumor, adjuvant hormonal therapy in ER positive tumor, and adjuvant capecitabine in triple negative breast cancer. There are a lot more developments going on in the neoadjuvant setting, so watch this space. I think this is my last slide. Okay, thank you for your attention. So I'm now ready to take any questions if there are any. Who will benefit for dual blockade HER2 with Perjeta? If we add Perjeta, is it the same regime? 3 FEC, 3 dosi, Herceptin plus Perjeta, neoadjuvant. Right, okay. Now, if we want to use the dual blockade, right, basically we want to use trastuzumab plus Perjeta. The chemotherapy backbone is different. In the trial that I've mentioned just now, it's not the 3 FEC or 3 dosi chemotherapy regime. So in fact, the one that gives highest rate of pathological complete response are the TCHP regime. So basically, it's a combination of paclitaxel plus carboplatin plus Perjeta plus Herceptin. So if you're going to use this dual blockade, then that's the best combination actually to use. But of course, that's like 4 drugs. So side effects are actually more, especially we observe more grade 3 diarrhea and also some myelosuppression with that combination. So you have to be careful. And then that is only in the neoadjuvant setting. So in the adjuvant settings, they dropped all the Perjeta, and it's just, and the chemo also they dropped in the adjuvant setting. So it's all just trastuzumab in the adjuvant setting for a total of 1 year. All right, okay. So next question. If patient develop recurrence after dual blockade, what would be the next choice? Okay. Now, when you say develop recurrence, what does that mean? Do you mean that there is residual disease? Okay, so I think I will approach this question in 2 different scenarios. So one, you give the dual blockade and then you proceed with the surgery, and then there is a residual disease, right, on the mastectomy or PCS specimen. Then you have an option of continuing with trastuzumab anyway, because that is what they do in the trial, or extrapolate from the Catherine trial and you swap rather than continuing with adjuvant trastuzumab for 1 year, then we change it to TDM1 instead in the adjuvant settings. So a second scenario is that if you do this, like the whole thing, you follow the trial already, do a blockade, surgery, and then adjuvant trastuzumab for a year, and the disease still recur, let's say 2 years down the line, the disease still recur, then what to do next? I mean, of course, if it's, you have to restage the disease, and if it's local disease, and you approach it as per local disease. But if it is in metastatic settings, then basically you have a patient who have failed trastuzumab, failed Perjeta. So in such setting, if you want to use HER2 receptor again, and the tumor still is HER2 receptor positive disease in metastatic setting, that in such setting, you may use the TDM1. There is data to support TDM1 use in such setting. Okay, right. Next question. Why is that we have to wait for 1 year after last chemo to start the immunotherapy when patient develop recurrence? I don't think I understand this question. I am not sure I have come across this. So maybe Miss Soraya can we give the mic to Miss Soraya? So she can elaborate this question. My answer is I'm not aware of this. I'm not aware of this. So we can either skip this question or Miss Soraya can elaborate on this question. I am not aware that if you want to start immunotherapy in breast cancer patient, you have to wait for 1 year after the last chemotherapy. To be honest, like if we look at lung cancer, for example, in other type of cancer, there's no, on the drug labels, there's nothing that say that you have to wait after 1 year to start the immunotherapy. So that's my answer to this, right? Okay, next question. How long do you give hormone for neoadjuvant treatment? Okay, so if you want to give neoadjuvant hormone for treatment, I'd say you have to be, very, very careful and very selective of your patients, okay? Try as much as possible not to give neoadjuvant endocrine treatment because the data currently are still iffy. There are a lot of trials ongoing to try and improve that. For example, try on hormone plus chemo or a stronger hormone like fulvestrant. As it is at this moment in time, if the patient can tolerate chemotherapy, I suggest you go ahead with chemotherapy. But if the patient cannot tolerate chemotherapy and you have to give neoadjuvant hormone, you have to explain it properly to the patient about this. And it is actually recommended aromatase inhibitor rather than tamoxifen, and the duration is between 3 to 6 months. I'm beyond time, is it? Are there any more questions? In a hormone-positive cancer, if the neoadjuvant chemo produces complete response after 3 cycles and the patient is requesting for conservative treatment, would you consider hormonal treatment as a conservative measures instead of surgical intervention? All right, okay. I think this one really is a discussion with the patient, right? I mean, I mean, there's debate about this. In fact, I've recently listened to prominent speakers, prominent oncologists, Dr. Adam Brufsky and Prof. Hugo, talking about there's a trial apparently ongoing in the West by the surgeons actually ongoing. Those who achieve pathological complete response are randomized to surgery or observation alone. So, I mean, it is an ongoing trial. So back to this question. So then if the patient achieves a complete response, again, it is about discussing it with the patient. I mean, some patients, at this moment in time, we're waiting for that data. So I think, well, I would complete 6 cycles and then surgery. That is what I would discuss with the patient. Look, I know this is what it is, but the data is not supporting that. You have to complete 6 cycles and then go for surgery, right? But if the patient is adamant, don't want any more chemo, don't want any more surgery, then, well, what to do? You have to oblige, right? Because at the end of the day, it's a patient's consent. So yeah, hormonal therapy, of course. Yep. All right. Okay. Next question. Post-surgery after neoadjuvant chemotherapy, HPE showed partial complete pathological. So it's not PCR then, yeah? Would you consider oral chemotherapy like Zeloda while waiting for radiotherapy? Okay. Again, when we're talking about neoadjuvant treatment, patient who had neoadjuvant treatment, we have to look based on the histology, whether or not it's triple negative, whether or not it's HER2, or whether or not it is ER positive. So let's say this is a triple negative, right? Triple negative breast cancer showing residual disease, then yeah, of course, definitely Zeloda. So I think the question is whether or not I will give Zeloda while waiting for radiotherapy. Yeah, I would, because sometimes the radiotherapy will be delayed unless you know for sure that the radiotherapy will be started in time. Yeah, like for example in private settings and in some university settings, you know, less machine breakdown. So you're confident that radiotherapy will start soon. Then yeah, I wouldn't give it concurrently with radiotherapy though. Okay, right. So next question. How frequent your follow-up will be after starting your adjuvant endocrine therapy for patients with ER/PR positive? Well, by right, we wouldn't be following them up too closely because it takes time to have any clinical response. So if you see them every weekly, you will not see the response. So usually we would see them every month. Yeah. Okay, next question. Is neoadjuvant chemo plus trastuzumab available in all KKM hospital? Any budget for trastuzumab? Yes, unfortunately, it is not. You have to KPK for the trastuzumab or pay and claim, unfortunately. Okay, next question. Is hormonal positive tumor but HER2 negative, received neoadjuvant chemo but did not achieve PCR? Do you give second-line chemo after surgery? Okay, interesting question. So you have ER positive tumor, HER2 negative tumor. You give FECT, right? In the neoadjuvant setting, you did a surgery, but there's residual disease. So then what do? Do you give a second line chemo, right? Or do you just put them on an endocrine therapy? The answer is we would just put them on endocrine therapy. There's no data yet to support that I can find anyway to support the practice of giving second line chemo after the surgery. Okay. Next question. In light of the pandemic, could anti-hormonal therapy be used for hormonal positive operable tumor due to a potential delay in surgery? Again, neoadjuvant hormone therapy, neoadjuvant endocrine therapy. I have reservation in recommending it. I mean, yes, I understand with the current COVID situation, and this is from Putrajaya, yeah, Miss Tan from Putrajaya. So what actually happened in HKL with chemotherapy? Those who are receiving chemotherapy in outpatient basis, we just continue. So in the neoadjuvant settings, if we give FECT, they are all as an outpatient. So it's come in the morning and then have the chemotherapy and then go home later, and then 3 weeks later comes again. So we're continuing that practice. It's those chemotherapy that require hospital admissions are the one that we are concerned about actually in this pandemic. Okay, right. Okay, so I think that's the last questions. Thank you very much. All right.
Thank you very much, Dr. Harissa, for very informative talk.
All right.
Okay, we will go back to backstage for next session before we go to the how I do it session.